Today I'm going to be talking to you about speech sound disorders. In the first slide, I have two categories of speech sound disorders. Number one is motor-based disorders affecting motor movements involved in the production of speech. That involves some type of deficit or disorder in the neural control of the speech mechanism. The second category is phonological based, which includes the broader aspects of speech production. That includes the actual perception of speech sounds and the cognitive aspects of the speech sound system. Phonological disorders then can show up in actual perceptual problems of actually being able to perceive speech sounds correctly, and deficits in the actual learning of speech sounds, which then results in children having difficulty then using speech sounds correctly or producing speech sounds. There could be some abnormalities at the cortical level that results in children having difficulty, again, learning speech sounds and the actual rules for using speech sounds correctly to produce words. Phonological impairments can also affect development of the complex motor behavior related to speech production. So if children are not producing sounds and or learning sounds correctly, then obviously that's going to affect their ability to actually motorically produce those sounds as well. So a phonological disorder specifically then results in a significant deficit in speech production or perception in, again, the organization of speech sounds and the actual, again, learning and using speech sounds appropriately. And this is compared to normally developing peers. Here I have some examples of articulation difficulties that a child may have who has a phonological disorder. So one instance here is a child who produces W in place of R. So they're actually producing the W sound in place of the R sound. So a lot of you may have heard children who, instead of the word rug, it's produced wug. So that's a common phonological processing error that we call gliding. Another error that you might see commonly produced here, I'm going to correct this quickly, this should be F. Okay, so here, a child who produces here, let's see, F in place of, that should be TH. Okay, so here another error. So again, a child produces the F sound in place of the TH sound. So again, the target word would be bath, and the child would then produce the word bath instead. Overall, if a child has a phonological disorder and presenting in the more severe range, they may have limited speech sounds in the words that they're trying to convey. Another error that a child may demonstrate is initial or final consonant deletion. So here the children are leaving off the beginning sounds or leaving off the end sounds of words. So for example, the word is boat and the child says bow instead, so leaving off that final consonant with final consonant deletion. And say the target word is cat and the child says at. Okay, so that would be an example of initial consonant deletion. So again, these errors you may see very young children demonstrate as they're learning speech and developing with their speech skills. However, what becomes more of a concern is, as I referred to up here in the slide, when normally developing peers are no longer producing these errors. So typically around the age 5 or 6, we say phonological processing errors should be diminishing, and it's when children hang on to some of these errors longer, usually past the age of 5, that it becomes more of a concern, and the child may need intervention to help correct some of these errors. So a child could present with many different phonological processing errors affecting their speech intelligibility, and then we would characterize their speech intelligibility and specifically their unintelligibility as being mild, moderate, or severe, again, depending on how well we can understand them. Here, I discuss specifically areas where a child may have deficits in motor production of speech. So, specifically, the speech disorders of dysarthria and apraxia relate to specific neurological impairments that affect a child's ability to actually move the articulators and musculature to produce sounds correctly. Here, traditional articulation disorders, again, children who have, again, more common articulation disorders are often here in the phonological based camp, which again can impact a child's ability to actually produce the correct motor movement for specific speech sounds if they are continually substituting the wrong sound for the target sound. What happens is that becomes an ingrained motor pattern, which is something we have to work on in speech to try and remediate. Another issue a child may present with is a tongue thrust, which is protrusion of the tongue during production of S and Z. Okay, so it's also referred to as a frontal lisp, and commonly. Again, what's happening is that the child is not using the correct placement of the tongue up on the alveolar ridge behind the teeth, and having correct airflow in order to produce a good S or Z sound. Another disorder that can present itself in children is developmental apraxia. And with children with developmental apraxia, their speech intelligibility is considered to be more severely unintelligible, and they have multiple errors, including here I have syllable omissions, consonant substitutions, and vowel errors. So there is really a combination of a lot of errors occurring, and the errors also are not always consistent, which again makes the child's speech intelligibility very difficult to understand. So overall, a child with developmental apraxia has difficulty coordinating motor movement to produce speech sounds. So it is a motor-based speech sound disorder, in that the child is not receiving the correct signals from the cortical level in order to actually coordinate the oral musculature to actually produce speech sounds correctly. So, to go back to here at the bottom of the slide, errors at the phonological level, okay, we could have a pattern of error, okay, so the pattern that the child would present with would be omission of final consonants in words, so we would call that final consonant deletion. We could also have an error called a substitution, okay, so when we're substituting one sound for another. And we could also have a child who has an overall limitation in the range of sounds produced, okay, so they have only a few sounds or a handful of sounds in their speech repertoire, and they're overall limited, okay? Okay? And a child could have limitations in syllable structures of words produced. So consonant blends like ST, L blends, so those consonant clusters. Some children, again, could have an error where they're not producing the whole syllable structure or consonant cluster when they are producing words. Okay, so here, obviously we need to look at the motor abilities of the oral musculature when we're assessing an individual who may have a speech sound disorder. Okay, and here we may decide to do a dyadicokinesis, which is a brief motor movement that we would have a client produce during an assessment, okay, which involves rapid alternating movements for certain sequences of speech sounds. Okay, so basically the speech sound sequence is Pudika, and we would have that client produce that sound repeatedly to assess their overall coordination for speech production. However, you have to use caution when you're using a dyadicokinesis for evaluation purposes, because obviously it's not assessing all of the speech sounds and does not have necessarily a direct correlation to being able to have conversational speech clearly, have clear conversational speech abilities. So again, the relationship between this task and actual speech production is unclear. Okay, so here we obviously have to assess an individual's oral motor abilities. Okay, however, we have to use caution in that if we're asking a client to do non-speech related oral motor tasks, such as puckering lips or protruding the tongue or moving the tongue out of the mouth side to side, those kinds of movements aren't usually traditionally used during speech production. So we have to kind of question the exact motor movements we're asking a client to do to assess their oral motor abilities, and making sure that it does relate specifically to speech production. Some comments about tongue thrust, in that some children have not necessarily diminished an infantile pattern of swallowing. Okay, so we know that when babies are very young, their tongue naturally protrudes, okay, when they're swallowing. And we all think it's very cute, and we know that, babies commonly do that. So what can happen is that that oral motor pattern never 100% completely diminishes as children get older. So again, this could manifest then into speech production, and here we would address, again, trying to diminish this more infantile tongue pattern into a more mature tongue pattern. Again, going over into articulation skills and feeding skills. Obviously, speech perception and the ability to perceive speech, okay, is critical to acquiring phonological skills, and then obviously being able to use phonological skills in your speech production. Okay, so obviously normal audition or normal hearing is critical when children are at that period of time, really from infancy all the way through the toddler occurs is when children are receptively acquiring their phonological skills, obviously in addition to receptively acquiring their language skills. Okay? So if a child does have any type of hearing impairment, that's obviously going to affect their acquisition of phonological skills. This would also include children who have chronic otitis media or frequent ear infections. This could also have an effect on a child's acquisition of phonological skills. So, obviously, if a child has a hearing impairment, it doesn't mean to say that they're not going to acquire speech, but it will be impacted depending on the severity of the child's hearing impairment. And obviously, when a child gets intervention for their hearing impairment, the age when that occurs, and obviously their remaining hearing abilities will also affect their overall speech skills. Okay, so we're talking about assessment of speech sound disorders. We can break up the assessment into 3 different categories. So it could be a screening, and then if we determine through a screening that the child may possibly have a speech sound disorder, we can then move into the identification phase and then move forward with more formal assessment tools and procedures. And then the outcome from that identification phase would be then coming up with a diagnosis, specifying here the nature of the disorder, the severity, the prognosis for remediation of the disorder, and also our recommended course of treatment if the child is determined to have a speech sound disorder. If you choose to do a screening, there are commercially available screening tools that you may choose to utilize that are really kind of parts of full articulation tests, and they may contain a small number of items that include sounds children are most likely to produce incorrectly. So the very common sounds that children may have articulation difficulties with at certain ages, or may continue to have difficulty with once they reach kindergarten. So the screening tools do have norms and cutoff scores for them to help you determine if a child is at risk of having a speech sound disorder. Instead of using a commercially available screening tool, you can opt to use a short sample of spontaneous speech, and then you can make an informal judgment yourself as the SLP about the number and type of errors. So you're looking at how often the error is occurring and the type of error, and if depending on the child's age they're expected to have that error diminished, then that would help you make a judgment then to move forward with further testing if there is a concern. So again, children who fail the screening phase are referred then obviously for additional testing. So now, as we're moving into the identification phase of articulation assessment, the first phase is we want to make sure we do a thorough case history. Okay, so collection of the child's developmental history is critical, and talking with parents, caregivers, and other relatives and teachers to make sure we're getting a thorough developmental history about the child. Here, we want to look at the ages that the child has achieved, general developmental milestones. We want to make sure that the child isn't demonstrating other delays in other areas of development that could cause cause a concern that the child may have developmental delays, and which can contribute to possibly the articulation and speech sound disorder that you might be seeing. We want a general history of the child's language development. Here, we want to make sure that the child did not have also a delay in acquiring speech and using speech, and also language. So we want to know if there was ever a history, a significant history in that area. We also want to, again, make sure that the child is acquiring vocabulary appropriately for his or her age, and making sure that there may not be also a co-occurring language delay in the child that you're evaluating. So here, we want to make sure that the child demonstrates normal motor abilities, sensory abilities, and obviously does not have a history of otitis media. So these issues here can then, if there are issues, can influence then a child being at risk for a speech sound disorder. We also want to get the opinion of family on the impact of the child's communication with others. So how well is the child being understood by others, and if the child is aware that they're having difficulty being understood, and any other types of negative feelings that may occur. Last but not least is we want to know about a family history of speech disorders. There is a genetic link oftentimes in families and of speech sound disorders. So we want to see, if mom mentions, oh yes, I went to speech therapy as a kid, I had trouble saying my S's and R's. So that would put then their child a little bit more at risk for also demonstrating an articulation difficulty. So there are a variety of articulation tests that you may choose to use during an assessment. The most popular articulation test is the Goldman-Fristow test of articulation. Oh, and I see a typo there. And again, the Goldman-Fristow tests consonant productions in the initial, medial, and final positions in words. Again, I'll try to upload a little mini video to show you how the test is administered, so you get a little bit of an idea of what that is like. But again, basically you're testing all of the consonants in the English language by showing the child a series of pictures with target words, including the various consonants. And the consonants will occur in words either in the initial position, they'll occur in the middle of the word, or they'll occur in the final position of words. You'll also do a story retelling activity to assess the child's speech intelligibility in conversation. And then the outcomes of the evaluation, you're also able to characterize the errors as omissions, substitutions, additions, or distortions. So omissions meaning that the sound is not being produced at all. Substitution meaning that the child is producing a different sound than the sound they should be producing. Additions meaning they're adding in an additional sound that shouldn't be there. And then a distortion meaning that they're trying to produce the sound, but either the airflow or the articulator placement is not correct, therefore distorting the sound. There is a supplement to the Goldman-Fristow, and that is the Kahn-Lewis phonological analysis. and you can then look at your scores and outcomes from the Goldman-Fristow using the Kahn-Lewis to then determine if the child is having phonological processing patterns to their speech errors. So once a child is demonstrating errors as an outcome of our testing, then we want to do stimulability testing. And that involves now actually giving a child models and cues and instructions and actually on how to produce the sound correctly. And we want to know this because we want to know how receptive a child is going to be to that type of intervention, if we were to consider intervention for the child. And also, if I'm able to give those cues and instructions to the child on how to correctly produce the sound, and they're able to produce it well, and then remember that, I may think about maybe giving them suggestions to work on at home with parents and teachers in order to help correct that error before I may consider seeing them directly for intervention. Okay, so you should also do a speech sample analysis, okay, in addition to your formal testing. So just to go back here, again, the Goldman-Fristow test of articulation is a formal test that comes out with specific scores and standard scores, okay. So, but in addition to your formal testing, you also want to do a speech sample analysis to further analyze the errors that are occurring in spontaneous speech. As I mentioned, you should do an oral mechanism, structure, and function evaluation, and make sure the child has had a hearing evaluation and there are no concerns there. Now we'd like to talk about intervention. And intervention, again, another name for therapy. Okay, so once we've determined that the child does in fact have a speech sound disorder as a result of our assessment, then we're going to create short-term and long-term goals that are measurable and addressing the specific articulation errors and difficulties that we have determined from our evaluation. During therapy, we're always going to have a choice of an activity, something fun for the children to engage in. However, it has to be somewhat structured in order to facilitate, again, here I have desired response. So you want to maximize your time in therapy in that you want to be able to get as much productions of the correct target sound that you're working on in therapy as much as you can. And your goals are going to state your nature of your feedback, so how much cueing are you and support are you going to give the child during therapy. We also have a criterion for moving on to the next step. So that's usually between 80 and 90% that we want the child to produce the sound correctly before we would consider that particular goal to be accomplished. So, an example of a short-term goal would be Johnny will produce the S sound correctly in the initial position of words given verbal and visual cues with 80% accuracy. So that would be an example of a short-term goal for a specific therapy session. So, again, when we're first starting therapy, we want to find some context in which the child actually can produce the target sound. So that's called the establishment phase. And we might see that the child is better able to produce alveolar sounds in words that have high front vowels. So that might be because the tongue is already up for high front vowels, and that's just a little bit easier then for the child to get up to the alveolar ridge to produce those sounds correctly. So there are different therapy approaches to try and help the child achieve correct production of the target sound. So the clinician may give direct instructions for articulator placement for a specific sound. Okay, so if I am going to work on, say, the S sound, I would cue the child to put their tongue up behind their teeth on the bumpy spot, which is the alveolar ridge, and try and gently push air across the top of their tongue and to produce a good S sound. Okay, so that would be an example of a phonetic placement approach for direct instructions on articulator placement and also airflow. You might also use a successive approximation approach, okay, where you have a child produce one sound that they already can produce correctly, and then gradually move into another sound which the placement is very close, okay, to the sound that they're already able to produce. So the example is here, moving from an L sound to an sound. Okay, so the L is already up, your tongue is up at your palate, and if you just move it off your palate and keep your voice on, it would turn into an sound. So if you want to give that a try on your own time, you can kind of see for yourself that that is a successful strategy to try and get a child to do, we call it the vowel R or the sound. So we want to make sure that the child is able to distinguish the target sound from the error sound. Okay, so we want to make sure that they know the sound that they should be trying to produce versus now the sound that they're trying to work on not producing. Okay. So there are also traditional approaches to articulation therapy. One is the Van Riper approach. Okay. And it goes through a hierarchy of steps as you move the child through these different steps in the therapy process. So the first approach with the traditional Van Riper philosophy is perceptual training and production training. Okay. So with perceptual training, okay, the child is simply really working on identifying the correct sound that they should be producing. And you're working on the child, again, identifying that correct sound versus the error sound. Okay? And it might be that you produce or provide lots of opportunity for exposure, for that child to get exposure to that target sound. Okay. And then you'll ask them periodically to discriminate, again, the target sound from his or her error sound in increasingly complex types of targets and situations. Once the child is able to really clearly identify the target sound versus the error sound, okay, then you can work on production training. So that's actually the child producing and working on producing the correct sound. So the first step is producing the sound in isolation alone. So you're getting, so say if it's the S sound, you're getting that child to produce the S sound in isolation as the first step. Okay. Sometimes you may have to put it in a syllable context or with a vowel to try and get the child to produce the sound correctly. But then once, if you're able to get it in isolation, your next step is then to move to syllable context for the child to work on producing it in those situations. And then it progressively gets harder and harder as you move up the hierarchy. Then you're going to ask the child to produce the sound in simple words. Okay, and then you're going, once that's mastered, then you're going to have the child produce the words in phrases and sentences, okay, with the target sound. Once they've accomplished that goal, then you're going to work on controlled conversation, or we say structured speech. Okay, so an example of that would be you would have the child talk to you about things they would find at the beach with a good S sound. Okay, and then finally, your last goal would be for the child to produce the sound correctly in spontaneous speech. So for that to happen, a child has to become very self-aware, okay, when they are making errors, be able to self-correct the errors, and be able to monitor themselves, their own speech production, in order to really minimize the articulation error that they are producing. So for children who have phonological processing errors, there are several approaches that can be considered, in that we really want to change the pattern of their speech production, okay, and the pattern of the errors. So it's not necessarily targeting a single sound, okay, but we're actually targeting a pattern such as final consonant deletion. So the example here is a child does not produce final consonants in words. Okay? So we want to work on that specific process to help the child start to produce end sounds in words and become more intelligible. So we're now targeting acquisition of a group of consonants in final word positions. Okay, so again, we're targeting that child being able to produce final sounds. It's not just one sound. Okay. Another example would be if a child who substitutes stops for fricatives. Okay, so if the child produces the word dop for stop. Again, they're producing the D sound instead of the S sound. So again, we would encourage them and teach them that sounds have those fricative sounds, okay? And working on the features of fricatives, okay, and teaching them the correct sound that should be produced for those target words. We may use minimal pairs, or words that have contrasting sounds, in order to actually teach the correct pattern that the child should be using. Okay. So minimal pair or contrast approach, okay, would be that if a child is substituting the W sound for the R sound, okay, again, we would have words that actually use W, okay, like won, like I won the race, okay, and then the word run, as in I like to run outside, okay, and making sure the child is able to clearly distinguish that the word won, W-O-N, is actually a separate word itself compared to then the actual word run, R-U-N, means that, again, the action of, running. So here, again, the approaches for phonological processing errors emphasize acquisition of the actual process of producing the correct speech sounds in individual words, okay, rather than individual speech sounds. Okay, so here, how often should a child have therapy? And really, it's dependent on several factors. So, obviously, if you're working in the schools, your caseload and schedule and Usually a district will have a specific mandate that for children who have traditional articulation errors, they get therapy 2 times a week for 30 minutes. Okay. However, if you have a child who has a more severe speech sound disorder, such as developmental apraxia or a motor-based speech disorder, you may recommend therapy more often, such as 3 times a week or 4 times a week for 30 minutes. So therapy can be delivered in a group or individually one-on-one with the student. And again, that's usually stipulated depending on the setting that you're working in and what the child truly needs in order to successfully progress in therapy. So again, we're going to determine our therapy goals based upon what is expected normally for children at specific ages as far as the sounds they should have mastered and acquired, and the impact upon the child's speech intelligibility. So which sounds have the greatest impact on others not being able to understand them. So those sounds we would maybe consider working on first to help that child be better understood with the people that they're talking with. Okay? And then we also may consider to start with sounds that are occasionally correct or were stimulable back in our stimulability assessment and during the assessment phase in order to give that child some beginning success in therapy before we would really tackle something that was more challenging or difficult for the child to produce. So finally, I'll comment on data collection. Okay, so obviously we need to measure progress during our therapy sessions, and we want to make sure we take data during our therapy sessions to determine what our, again, initial baseline is with the child when we start therapy, and then continue to take data during our therapy sessions as we work with the child to see if the child is progressing and we're seeing movement towards increased production of the target sound. And again, the criterion is usually 90 to 80% to considered to be the mastery level for specific goals before we move on to another goal in therapy. Sometimes we may move on to another goal, even though we may not have hit the 80 to 90% quite yet. If we feel a child is starting to get bored with working on that same specific task, we want to kind of change things up a little bit in our therapy session. So again, that would involve us periodically going back, okay, and monitoring the previous skill to ensure that the child is continuing to make progress in that goal that wasn't quite that 80 to 90% mark. So we would consider dismissal from therapy, obviously, when all of our goals have reached 80 to 90%, okay, as measured in spontaneous speech, okay? So obviously the goal is for the child to have successful production of the speech sounds at the spontaneous conversational speech level, and that's our ultimate goal. And when we start to see self-correction, like I mentioned earlier, when a child is talking, actually catching themselves, producing that articulation error and then self-correcting it, that's a really good sign that we're seeing for that child to be on the road of really truly remediating it and being more self-aware and responsible for their good speech production and eliminating that articulation error that they have. So that concludes the recorded lecture for speech sound disorders. And please feel free to contact me, email me, or post a question in the discussion board if you have any further questions. Thank you.